morning, everybody, and welcome to all of those outside of California who are joining us today, and all of those inside of California for joining us today. Today is part 2 in our community pathway conversation. Can you advance the slide? So for those of you who haven't been with us before, this learning forum is part of a larger learning series focused on community, child, and family well-being and the implementation of the 5-year prevention services plan. The learning series is an opportunity for counties to learn from subject matter experts, engage one another about how to create a prevention infrastructure, to strengthen cross-sector relationships, to position counties and jurisdictions to better examine their capacity and ability to effectively partner and engage with parents and youth with lived experience, to measure and decrease racial disproportionality, and really how to anchor service delivery systems in primary prevention, extending downstream from there and prioritizing resources in the most upstream way possible. Next slide. So again, we're on part 2 of our learning series around the community pathway. And last month, we examined the foundational and critical components of building a pathway that ensures communities are connected, helping to keep children and youth safe and families thriving together. Today's conversation will provide the context and considerations specific for California's community pathway, and then we will have the opportunity to learn from true jurisdictions outside of California about how they are building a community pathway as part of their 5-year prevention plan. As with each of the learning forums, we start with an acknowledgement of our collective history as a step towards reconciliation and a constant reminder of our intentions, purpose, and goals for why we are coming together. In order to address centuries of collective harm and trauma to African American and tribal children and families, we must make an intentional choice to rebuild communities in an equitable manner. I acknowledge that I am sitting on the traditional territory of the Kahula people, who are the rightful owners of the land we now call the Coachella Valley. I also want to acknowledge and pay my respect to our African ancestors for their enslaved forced labor they endured for this country's development and economic progress. We highly encourage everyone to do their own research on these aspects of our history, and there are a couple of links in the chat to do so. So now I'd like to introduce our speakers for today. I have the great privilege of introducing Dr. Catherine Eisenhower, who is a friend and esteemed colleague. She is the Chief Executive Officer of Shield for Families, a private nonprofit organization that offers over 30 programs for families who reside in South Los Angeles. Since Dr. Eisenhower co-founded Shields in 1991, the organization has grown to employ over 300 staff with a $30 million annual budget to provide comprehensive services to more than 20,000 families annually. Importantly, Dr. Eisenhower is a member of California's Child Welfare Council and co-chairs its Prevention and Early Intervention Committee and co-chairs the state's Family First Prevention Services Advisory Committee. Second, Natalie Carver serves as the Deputy Director for Office of Community Partnerships at Washington, D.C.'s Child and Family Services Agency. Natalie oversees the agency's primary, secondary, and tertiary prevention strategies implemented through grants, contracts, and MOUs with community-based organizations and sister agency partners across the district's Government, Health, and Human Services cluster. Natalie's team is responsible for the implementation of the district's 5-year prevention plan, Putting Families First in DC. Third, Dr. Sharon Davis is the Community and Family Services Director at the Connecticut Department of Children and Families. In that capacity, she provides the strategic direction and project management of Connecticut's Family First Prevention Services Plan statewide, collaborating with department leadership, community programs, and families to develop and implement the approved prevention services goals and plans. And Ken Meisegland is the Bureau Chief of External Affairs at the Connecticut Department of Children and Families. Ken is responsible for the oversight of the department's communications division, Office of Community Relations, and enhancing the department's prevention framework, which includes implementation of Family First Prevention Services Act plan, which he was co-lead in the development. And finally, Dr. Kush Cooper, who is an adjunct professor at UCLA Luskin School of Public Affairs, as well as the CEO of Informatics, a consulting firm serving public and private organizations in the area of foster care reform, LGBTQ youth and systems, implementation science, and leadership development. And most importantly, she serves as the facilitator for this learning forum. So welcome everybody, welcome to our presenters. I'm looking forward to a very informative 2 hours. Kush, I'll turn it over to you.
Thank you, Dana. Good morning, good afternoon, good evening, wherever you are, welcome. As Dana mentioned, this is part 2 of a 2-part conversation on building a community pathway to services. And I'm going to do a brief refresher of part 1 so we can all be starting at a level playing field. So while the idea of using federal foster care 4E funding for prevention of child welfare involvement is new, the prevention conversation has been going for some time, particularly in the public health and even probation arenas. In the prevention discourse, community pathways become important as they allow families to access local, culturally relevant, and trusted services and supports without having to come to the attention of crisis-oriented and often sanction-based systems, in our case, child welfare or probation. Family First funding has forced a larger conversation in child welfare, particularly about community pathways, and we've put a capital C and a capital P in front of the words and made it a key concept in the current prevention conversation. But again, it's not a new concept. If you're gonna build a community pathway that the community will trust and use, you are going to have to engage that specific community to understand that community's needs, their wishes, their aims, their goals, and their preferences. Several briefs and resources in past learning forums, both local and national, have provided a lot of guidance on best practices to do so. We must weave together a comprehensive array of services that the community pathway, the referral pathways lead to, that address the range of challenges families face across multiple domains. The social determinants of health are one such set of domains. It's a checklist, if you will, to see whether you've got a comprehensive array that touches every sector. Protective factors provide another set of domains as a framework to build on an array of services, especially for those families who have been put at risk by structural racism, economic disadvantage, and colonization. Jurisdictions have flexibility in designing community pathways to be funded by Family First. They can use contracted providers, select from EBPs in the Prevention Services Clearinghouse to be reimbursed for, and leverage existing service infrastructure already existing for non-child welfare agency partners, such as departments of homelessness, behavioral health, public assistance, etc. Overall, in our current prevention arena for child welfare and probation under Family First, jurisdictions are encouraged to elect to have community pathways because of these benefits. You can serve families outside of the child welfare system. You can finally start to address the what if we had just provided X question. It allows families to voluntarily receive prevention services, again, by those trusted community-based providers. You can leverage 4E funding now in this conversation through Family First. And all of this is supporting a general paradigm shift that you see in child welfare and probation to build community capacity and strengthen families upstream. So we prevent maltreatment itself and child welfare involvement. And in general, building these community pathways require conversations and partnership across family serving systems to develop an integrated and holistic network for children and families that doesn't duplicate services and drain already limited resources in that way. Family First outlines key activities fundable by 4E. This doesn't mean that other activities are not possible to bring into one's community pathway using other funding streams, but the Family First activities are determining eligibility for services for quote unquote candidates, developing and monitoring child-specific prevention plans, referring connecting families to EBPs, providing those EBPs, conducting ongoing risk and safety assessments, monitoring the fidelity of those selected EBPs in a robust continuous quality improvement process, and then reporting data on the outcomes of child-specific services to the federal government. And there are some other, I won't go through all of these in detail, you have them in your deck. There are some other key policy features that Family First funding now brings to the community pathway conversation. The 4E agency, child welfare or probation or tribe may contract out 4E administrative activities to community-based providers, but they still have to be supervised by the 4E agency or tribe. Only the 4E agency, including a tribe who is under a 4E agreement, is permitted to make the determination that the child is a candidate for Family First reimbursed services. There isn't any requirement that there is an open child welfare case for a child who's receiving 4E prevention services. And the Act doesn't address what, if anything, a 4E agency must communicate to parents about a child eligibility for 4E prevention services. There's an imminent risk conversation, but it is not necessary to share that imminent risk conversation with families to make sure that they receive the prevention services. So as this conversation has evolved, particularly using in the Family First context, the California Child Welfare Council's Prevention and Early Intervention Committee has created recommendations in this regard so that California's jurisdictions, counties, and tribes can start to develop robust community pathways that will be successful. And for those recommendations, I'm going to turn it over to Kathy Eisenhower. Kathy, please go ahead.
Thank you, Kush, and good morning, everyone. I'm very honored today to present the PEI Committee's recommendations. Before I get started, I want to acknowledge my co-chair, David Swanson-Hollingworth, who is also the Ventura Director of Child Welfare, because we have been fortunate enough to be able to push this agenda forward. You can go to the next slide. For those of you who are not familiar with the California Child Welfare Council, I just wanted to give a little bit of background so that you can understand where these recommendations got their early start years ago and grew to where they are today. The council was created in legislation in 2006 in order to address what I think the Family First Act really acknowledges now. So California had an early start there. We know that we have to work across systems if we're going to address the issues in the child welfare system. The Prevention and Early Intervention Committee was one of the first 4 standing committees that the council developed to work to focus on prevention and early intervention and all the things we're really talking about with the community pathway, strategies to keep families out of the child welfare system. Our membership includes over 40 individuals, and we truly represent what I'm getting ready to present to you in the recommendations, the vast section of folks that you really need to pull together to put community pathways in place. And so that's CBOs, those with lived expertise, public agencies, private entities. Those are all members of our PEI committee that help to put these recommendations together. If you could go to the next slide. When FFPSA was passed, that really gave our committee the opportunity to push our agenda forward. And I want to be very clear that our agenda, specifically going back to what Dana said, was to try and address the disparities and inequities in our system, with the ability to provide families with resources in their community. I'm going to be honest and say that moving prevention forward has been an uphill battle over all of these years. I have had the honor of being the co-chair of the PEI committee since it began in 2007, and it has been a struggle to get to where we are. And so with the passage of FFPSA, we were ecstatic that the department asked us to work with them, and we've been able to push forward recommendations, which I'm sure many of you have seen, for the development of the plan, and now ultimately to get to where we are today with the community pathway recommendation. This has included David and I also serving as the co-chairs of the state's advisory committee in order to oversee the development of the plan. Next slide. Something that happened either because of FFPSA or because finally prevention is beginning to get the attention that it needs, and we're truly looking at what is happening in our system. Also throughout the country and definitely in California, we also saw a growing momentum for shifting our system from mandated reporting to community supporting. And the recognition that that cannot happen unless we have the resources in our communities in order to be able to offer families the supports that they will need. And so with that, we intertwined our recommendations to acknowledge that in order to be able to do a community pathway, our policies and practices around mandated reporting have to change also if we are going to have success. And again, addressing the disproportionality in our system, the inequities that many of our families have experienced for decades. The community pathway recommendations were submitted to the Child Welfare Council in our March meeting. And I want to say that they were unanimously approved and acknowledged by the state as the way that we are moving forward in California. If you could go to the next slide. And the next slide. So I'd like to first go over some of the core tenets, which I've already kind of referenced, but our recommendations are meant to be in line with California's vision for child, family, and community well-being, centered on equity, social justice, respect for tribal sovereignty, and it requires that we implement these plans in all of our counties in order for families to really have the supports that they need. That, as has been mentioned before, that we can't do this without including the families that this impacts. that we have to work with our communities, that we have to work with the families that have been impacted by this system in order to develop a community pathway that is going to be effective for them. You know, and with California as big as it is, that means that every county has to really develop a community pathway that is specific to their needs. And in some counties, that means multiple ways of approaching things, because the counties are so large and the populations are so diverse that we must, again, develop and design a system that works for the families that we're talking about. Recommendation 1, if you go to the next slide, in order to address what I was just talking about, our first recommendation was to implement a statewide mandated reporting to community supporting task force, to really take a look at what is going to be necessary to change in our system to make this effective, to take a look at the current laws, to take a look at our mandated reporting training. We know that part of the difficulty with the community pathway is our mandated reporting system. We must be able to get our families to the resources and supports that they need, and do so in such a way that does not violate our existing laws. So what do we need to do to change our practices and policies in order to make sure that the community pathway is available for our families and be able to provide the supports and resources that they need? So you see some of the issues that we listed up here. Again, any kind of legal and legislative reforms that are necessary. What kind of redesign of our mandated reporter system do we need to put in place? And what other policies and practices are necessary in order to make this transition occur? Recommendation 2 is putting in place, if you go to the next slide, the accountability and the oversight of this process. You know, and that includes from the shift from mandated reporting to community supporting to the implementation of the community pathway. That, again, as has been said multiple times already this morning, is that our pathways are not going to be successful if they are not built by and for the families that are in our communities. We have to have an intentional focus really on those communities that are impacted by the disparities. And we have to have those families at the table, not just when we're designing, but throughout the entire process in order to monitor what is occurring, in order to recommend any changes that are necessary and address any gaps that are identified in our system. We recommended that a state community pathway advisory group be put in place in order to oversee from the state level and provide input on such things as what additional EBPs do we have, taking a look at our data to see if we are on the right path in our implementation process, and to encourage every county to implement a community pathway oversight committee at the local level to do just what we're talking about, to really on the ground provide the input about what is needed, what gaps may exist, and to provide input into what it is we need to do in order to make our community pathways successful. Recommendation 3, if you could go to the next slide. We also felt very strongly that there need to be consistent definitions. As we roll out the community pathway across the state, we all need to be talking the same language, understanding that what we mean when we say different things, and ensuring that as we roll out to the greatest extent possible, we are building a framework so that our families can benefit the most. We recommended that these core components include no wrong door, that families can access the community pathway wherever they are, whether that be through their church, through a community-based agency, through a neighbor, through a friend, through self-referral, that they can access these resources from anywhere, that we build on our existing resources. I think too often we have made the mistake of trying to build new systems when we get new money, and we will not succeed if we do that. We have to take a look at what we already have existing in our community and build our community pathway upon what is available already if we're going to be sustainable. We should utilize, our funding to fill gaps, to address issues about sustainability, to develop infrastructure, but I think it is critical that we build on what our families already know works in our communities. You know, we need to define what the roles of are all the partners in the program, and more than anything, we have to build on the community and the expertise that already exists there. You know, probably many of you are aware of entities in your community that aren't part of the traditional child welfare system, but it's where our families go to get the help and assistance that they need. When we're building community pathways, we need to take that knowledge, that expertise into account. We need to listen to our families and again, build on what we have so that we can ensure that this is not a one-time change, that this is a sustainable change that is going to define our child welfare system for, as long as we can see in the future. Recommendation 4 is around, next slide, please, is around financing. I know that this is, again, where we struggle, but we think it is critical that, again, go to people in the community. We recommend that you do a community pathway inventory that is not just focused on the funding that is out there and available, but that the resources that already exist, the human capital that exists in your community, and find, what is unique, to your county or to those communities within your county. And again, as I said before, that every effort should be made to build on what we already have. How can we blend funds? How can we leverage funds? How can we utilize new resources that are available in California in the community pathway? I always mention here that, we look at CalAIM and how CalAIM has changed in California. For those of you outside of California, that is our, healthcare system. There are now benefits available for community health workers, for doulas. We need to figure out how our communities can take advantage of some of these new benefits so that we can develop infrastructure and support sustainability in our communities and ensure that the community pathway is embedded in the work that we do. We need to figure out how we're getting money out into the community. One of I think the difficulties right now is that many of our non-traditional, very grassroots organizations really don't have access to traditional funding. We need to take a look at how we are issuing our RFPs. Is there a better way to do this? Is there a way that we can get to those grassroots organizations where our families go, where our families, trust, who it is they're reaching out to? How can we get them the resources that they need so that, again, we can build a strong community pathway? And as part of this, again, we're asking the state, back to clear definitions, that we get clear guidance on payer of last resort and imminent risk so that we are all talking the same language and being able to take advantage of the resources that are out there already. Recommendation 5 is really about measurable outcomes. And, again, this is outside of the data that we know we have to give to the federal government. But if we're going to be measuring the success of our community pathways, we need to talk to the families in the community to get their input on what those positive outcomes mean to them. Things like extended access to, to the resources that are available. Are we building stronger networks and partnerships in the community? Are families being able to get the services they want, when they want them, from whom they want them? And then again, what kind of impact is that having on their child welfare involvement? Are we actually able to keep families out of the system when we're doing this work? So again, we're asking that this be a part of what your community pathway advisory committees do. At the state level, again, looking at the data in the larger picture about are we being successful throughout California, but at the local level, really working with the Community Pathway Advisory Committee to identify what are those specific outcomes that are going to mean success to you for your community pathway, and continuing to review that data on a regular basis to ensure that we can measure our progress on what we're doing. Are we building a system that is effective for our families? Recommendation 6, and again, you've heard this before, but we want to emphasize that California took a bold step when they put in their community pathway. It is not just about the EBPs and having families access those EBPs. It's really about building a community pathway that provides whatever a family wants, regardless of that family's eligibility for a family first. And so I think that is a critical thing to recognize, because we now have the goal and the opportunity to get to families before they ever are at risk for child welfare involvement if we build our community pathways correctly. So, again, making sure that as we're doing this, we're pulling in primary prevention efforts, that we are building a full continuum of care for our families, and that we really help our community-based organizations, to identify what kind of technical assistance they might need to build out the services that our families are identifying that they need. But this also includes making sure that we are prepared to offer EBPs for our families that are in need of them, and giving our CBOs the opportunity to train in those EBPs and develop the expertise in those areas. We already know that many of our counties don't have many of the EBPs that are identified in the plan. And so how can we make sure that they have access to the training and the resources that they need in order to put those in place? We also know that there are many other EBPs out there that might be more appropriate for our families that don't meet the level of, well supported in the plan. And so how can we help move those EBPs in that direction? How can we identify EBPs or community-based practices that we may want to try to raise to the level of well supported so that we can incorporate them in our plan? Recommendation 7 is then about the training and technical assistance. We really felt strongly that we should develop training and TA that is specific to community pathways. So feel like community pathways are a unique part of the plan, and that we need to provide the insight around financing, around what I was talking about, around EBPs, about developing a community continuum of care for our families. So again, making sure that the training and the TA is specific to the community pathway, that it utilizes training and vendors that represent those who are a part of the community pathway at the county level, that the TA be available to grassroots organizations, and that we align the training and the content with the vision for families, child and family well-being system. So since we had these recommendations approved, I'm already on implementation in my head. Since then, we have been working hard in order to get them implemented. So already in terms of the task force, we have identified co-chairs. We have a working group that is meeting in order to develop the charter, to identify the membership process in order to get the mandated reporting to community supporting task force implemented and on track. That task force, as you saw in the recommendations, is reporting to the California Child Welfare Council at all of their meetings about their progress. And we hope to have a report completed by the end of this fiscal year. What is extremely exciting to me is that CDSS, our California Department of Social Services, is finalizing a community pathway work plan to ensure that our implementation is aligned with the approved recommendations, as well as we are now getting the FFPS Advisory Committee back together and focused on the actual implementation of the recommendations. And, again, the PEI committee is continuing to work further on these community pathway recommendations, particularly in the area of financing, so that we can bring forth some additional recommendations that are going to support the financing of community pathways in counties by hopefully identifying strategies, addressing barriers across departments that might impact our ability to access some of that funding. Before I close, I just want to say a few things. This is going to be a long process. I know that. I've been working hard to get prevention recognized and at the forefront for many years, along with a lot of other folks. And finally, I feel like we have that momentum. We have the acknowledgement finally that our child welfare system not just needs to have a paradigm shift, but it needs to be transformed. Those of you who don't know me, I started an agency years ago specifically to address this issue. Because in South Central Los Angeles during the crack epidemic, families were being torn apart by the child welfare system because there were no resources available. Some friends of mine started an agency to specifically address that, but here we are 33 years later, and we still have the same disparities and disproportionality in our system. And it is time to make a permanent change in how we do business. I have something today that I haven't had before, and that is hope. What I have seen over this process of the development of the recommendations, and I could use all the buzzwords about collaboration with the state and things, but that is not what I want to say. What I want to say is that we have truly worked together side by side. The table has been those with lived expertise, the community, the state, all working together both to develop these recommendations and now with a commitment to move them forward. And that gives me hope, hope that we can do this transformation, hope that our families, hope that we can spread our hope to our families so that they can have the resources and supports that they need in order to keep them out of the system, to make them healthy, thriving, and again, to meet California's vision of, child and family well-being. Thank you. I'll turn it back to you, Kush.
Since we're doing great on time, Kathy, there are a couple of questions in the chat, and I was wondering if I could raise those up now. All right, so as you can imagine, it's probably not the first time you're hearing questions in this regard. We've been doing differential response in California for some time. So there's one question in the chat about sort of how is this what's being proposed different from differential response already in existence, and how will pathways reach out to parents and families prior to their involvement in child welfare, sort of leveraging some of the work that's already been done. And then there's another question that's related to community to differential response also, which is how are returns on investments going to be framed, particularly path one, which are families that have been deemed to be at low or no risk. So just anything around this sort of differential response parallel, so to speak.
Okay, you asked me many questions, Kush.
Yeah, and I can have some Cindy come off mute and specify hers in a moment. But just in general, how is this related to or not related to differential response?
Well, I think you actually included that in one of your questions. I think the big difference here is that differential response families actually touch the system itself and are referred out. With the community pathway, what we're looking at is getting to families before they've ever touched the system, and so I think that is key, is being able to offer those supports. And again, I think this is in alignment with our shift from mandated reporting to community supporting, so that families that may have, because of the laws, been reported previously, with the change in the law, even in California now, with the change in the law regarding neglect and its relationship to poverty, families that, again, previously may have been reported are now going to be in the community and being able to access resources. But again, as I said earlier, I think that if we build our community pathways correctly, then we could hit families, throughout the continuum. Families that have made just having that first risk, happen in their lives. Somebody, loses their job so they can't pay the rent, which, if we can step in and intervene, we may stop a spiral from occurring that leads that family down a pathway which leads them to child welfare involvement. But if we can provide those resources right up front, we can stop that trajectory.
Great, thank you. Thank you. And then Cindy, I see your hand. Do you want to come off mute? We're still doing okay on time. Go ahead and ask your question.
Okay, so the question that the ROI I was referring to with regards to differential response path 1 is release of information, not returns on investments. And sorry.
Okay, Cindy, could you say your question, because I wasn't able to see it, so.
So we've run into a stumbling block here in Humboldt County. Our county council is now requiring us to get a release of information for differential response path 1, which from my standpoint and my previous experience in child welfare is kind of nutty, but that's where they're coming from. And so they've kind of put a whole stop on what we were envisioning with our comprehensive prevention plan as sort of the pipeline of those families that mandated reports are submitting reports to child welfare. And we used to be sending all that information to our what is comprising our community pathway. But now that they're requiring a release of information because they're claiming that it's a violation of the family's confidentiality. And we're talking about path 1 only. So, we need some help around working around that. And that's what I was asking about.
Okay, so what I would actually do is suggest you talk to LA County. I know that there are some other counties in doing it. I think people have done it differently in different places, but yes, that release is I think probably an issue everywhere. I know that in LA, we have built it into the actual process. And so that families are talked to and they give their permission to be referred to another agency so we can share the information. But I think that, again, in the community pathway, we're not talking about necessarily those families, but I think another issue, and I'm just going to throw it out, is how do we make sure that those families, even though they have to be approved by the department as being, at imminent risk, how do we keep their information separate and confidential also? So I think that's another issue along the way. And I don't know if that answers your question specifically, but I do think there are ways that you can build in place those path 1 families that you're talking about, the ability to work with them for them to give their permission to release the information to other families. I don't know if that answers your question directly or not.
You got a thumbs up from Cindy. So good there. And then just sort of the last set of questions actually just tease off of what the current discussion just was. How are services in the community pathway going to be interacting with child welfare information systems, and how do we ensure that this is happening in a way that protects the information about families, doesn't result in an expansion of surveillance? That's been a general anxiety around community pathways and claiming and reporting.
Okay, well, I will do my best to explain my dream system. But, I think there are definitely ways to do it. It is an issue. That's what I was alluding to further, but I think we can get creative as a state. For example, using a third party to be able to give that data to that can protect, and give the family an identifier so that the department itself, the Title 40 agency, won't see the information, but will have what they need in order to determine, their candidacy. So I think there are ways to do it, but again, I think we're going to have to be creative about it, because I think the last thing we want to do is, extend that over surveillance we keep talking about. And, and our families more than likely won't use the resources. We all know that it's something that keeps families right now from asking for help because of their fear that they might end up in the child welfare system. And so I think it is a key issue that we have to deal with. And again, that would be my personal recommendation, is that we get creative and use an additional, like data collection agency in order to safeguard the information and yet allow our Title IV agencies to be able to identify candidacy.
Great. Thank you, Kathy. And And Michael, we are going to move on. I do see your question, Michael Anderson, about how to monitor the fidelity of EBPs in community pathways. I invite you to sit tight and listen to the 2 presentations coming up. And then we can get back to your questions after that, because they are going to talk about EBPs and sort of some of the systems they've set up for fidelity. So hang on. I'll get to the remaining questions at the end. Thank you so much, Kathy.
Thank you, Kush.
So now I am going to turn it over to the Connecticut Department of Children and Family Services to give you an idea of how they are conceiving of their community pathway and its components. You'll hear after them from DC. And I love the difference between the two. And it goes to show that folks can really engage in creativity that addresses their local concerns, size, type of communities, type of infrastructure that exists already to be able to build their community pathways. So without further ado, Sharon, please go ahead.
Good afternoon, everyone, and thank you, Kush. Such an exciting conversation so far, and we look forward to this continued conversation. So my name is Sharon Davis, and I'm here along with Ken Meisler on behalf of our Commissioner, Vanessa DeSantis of the Connecticut Department of Children and Families. So there was a lot of discussion around community pathways, and earlier what you talked about when we talk about community pathways, I'm sorry, next slide, Kush. I have to remember to say next slide. Community pathways really allows families outside of the child welfare system to access Title IV-E services. On this particular slide, you see our candidates, our community pathways candidacy population. These families were selected based upon available data and the expertise of our Family First Community Pathways Work Group. Our candidacy population definition is very broad, and it was really intended to provide prevention services to families with a heightened risk of out-of-home placement. When we thought that if we could engage these families and we say upstream, which is earlier than any involvement with before any involvement with our child welfare system, and connecting them with the right services, we would see a decrease in calls to our care line. And our care line is the department's agency's 100 hotline number. I guess we call it a care line. I think some people call it a hotline. And that those calls that ultimately come in that are not accepted because they don't reach the level of child abuse or neglect, but that we would also see a decrease in the number of families really becoming involved in our child welfare system. What will be dropped in the link, as I understand it, is Connecticut's plan. And what is highlighted in it are the pages where we further describe our community pathways calculation. Next slide, please. So we're currently in contract negotiations with an organization outside of the department that will be responsible for the care coordination of programs and services for our community pathways population. This CME will, and thank you, Kush, perfect timing. This CME will build relationships and will collaborate with our community partners to identify and engage potentially eligible children and families. Partners such as schools, sister agencies, faith-based organizations, our judicial system, and other community providers will be encouraged to refer families directly to our care management organization unless there's an observed safety concern that indicates a call should be made to the department's hotline. 211, as you can see here, will also work with us. We are working right now in developing this some trainings for them so that they will understand the eligibility criteria for Family First so that they can make a decision as to whether or not to make a referral directly to the care management entity or maybe to the care line if it is appropriate. In addition to that, our care line also accepts calls and will make indirect referrals for calls that are ultimately not accepted via the mandated reporter letter. So now what I'm going to do is just for the next few slides, I'd like to bring in my partner, Ken Meisler, and he's going to talk a little bit about the roles for our department, as well as our care management entity. Ken?
Great. Well, thank you, Dr. Davis, for that great introduction to our work. And Dr. Davis and I are certainly humbled to be with all of you this afternoon or this morning, depending on where you are around the country, right? So with the implementation now of our community pathways and our care management entity, the Department of Children and Families is certainly taking on a new role. And that may cause some to be a little uncomfortable, right? For decades, what has our message been to community providers? Call us, call DCF. When in doubt, get us on the phone. I truly appreciated what Catherine said earlier about working in the height of the crack epidemic. That's when I started my career in '89. And you know, I think back of what we didn't have then and what we're trying to implement now. We also realize that part of our new role means we have to really work with the community on this risk-averse, liability-driven mindset. Connecticut has very, very clear mandated reporter laws, and we have had a number of highly publicized cases where mandated reporters have actually been arrested for not making a report at all or failure to report in a timely manner. And that has shocked our system over the years. So we have continuously seen increases year after year in child abuse and neglect reports. However, the acceptance rate has continued to go down because we are not getting families in Connecticut to the right type of service. There's too much dependency on child protective services or surveillance, and there's not enough focus on support. And that is what we are hoping to change here. So as far as DCF, now we are partnering with the community. We are the behind the scenes funder for our care management entity, who now will be responsible to receive those families where abuse and neglect is not present, yet we know they would benefit, or somebody believes they would benefit from some type of support. If you can go to the next slide. We know that we want to navigate families, as I said, to what they need and what the providers think they need. It was a number of months ago that I attended a meeting with our local boards of education here in Connecticut and some of their union representatives talking about child abuse and neglect reports. And one of the things that we heard loud and clear just from teachers alone is they don't know where to send families. They see in front of them patterns developing. They see kids at risk. They also see those intergenerational patterns of abuse and neglect, and they're searching for, where do we go? Well, in our community pathways group, there's three actual ways that families are going to get help. And I think they actually build upon each other. First and foremost, we're going to make sure, our entity is going to make sure that the economic and concrete supports that families need are addressed. I'm going to talk in a little bit about the work we did with families with Liv's expertise. But one of the pieces that they came up with time and time again is, what do we need to be prevented from having a call made on us? We need stable housing. We need access to food when money gets tight. We need consistent transportation. So those families that are struggling with those economic and concrete supports now have a way to have them met. We also know that there's going to be an array of clinical services, evidence-based programs, like we've already mentioned on the call a number of times, that can be accessed through our community pathways work, along with other effective services that may not be evidence-based, but in fact, we know what they in fact work. And then there's the connection here between the clinical services and the economic and concrete supports and engagement with mentors who are families who have lived expertise. So now families who are walking the walk and talking the talk are going to be connected to those same families who need support, both on a clinical way or economically and in concrete, tangible supports. Think of Maslow's hierarchy of needs. What do we need most in a time of crisis? We need to know where we're going to sleep, where we're going to eat, are we going to be safe, and then move to the underlying reasons of why perhaps that support is needed in the first place. You can go to the next slide. Sharon?
I think we missed one slide. There was, so back one, Kush, if possible. Oh, I guess it is missing. Sorry about that. Okay, it's my turn. So we recognize that there are racial disparities that can occur in every decision-making point in the child welfare system. Next slide, please. In 2019, our family assessment response saw an increase in number of families of color involved in our child welfare system. Next slide. We saw more families of color referred to investigations from 2015 to 2018. And in 2019, there was a decline, though there still was a concern with the number of families referred. Next slide. Overall, we saw this disproportionate number of families of color across our child welfare system. And to address this, we heard from families during the planning phase of Family First that families needed an organization outside of our child welfare system that had a racial justice and trauma-informed lens that could facilitate preventive services. Families felt, and as was noted earlier by Catherine, that when asking for help, they preferred to go to a trusted provider and did not require child welfare involvement. So we were very intentional in bringing the family voice to the ongoing continuous quality improvement and working with our care management entity to ensure that their voice would inform our service array and delivery. Next slide, and I'm going to pass it back over to Ken.
All right. So how did we engage youth and parents with lived expertise to inform our plan? Well, I wanted to go back that our state of Connecticut Family First Prevention Plan started in development in the fall of 2019, right? Seems like ages ago before that little pandemic crept up on all of us. And it took us almost 2 years to complete our plan. And what we did is we received input over the course of that time from over 400 unique individuals. We met with and collaborated with over 10 different state agencies here in Connecticut. We met with private providers and community partners and individual therapists and grassroots organizations. Anybody who wanted to come forward and be a part of one of 7 work groups to inform Connecticut's plan, we said yes. A big component of that was we wanted to capture the voice of parents and youth. And so what we did is we asked our statewide advisory council to put the word out that we wanted to meet with a group of parents and youth on a consistent basis and gain their insights. And over 100 families registered, and we actually had 44 unique families participated in 3 work groups that entailed about 90 minutes each. And what did we learn from those individuals in our community who could benefit most from a community pathways organization and support? First of all, that the entire state of Connecticut system, the child welfare system, child protection, behavioral health, education, really needed to lift the stigma associated with asking for help. I hope the pandemic has had the impact it has in Connecticut on lifting the stigma. It's too negative to currently say to someone, oh, I think I need help. Connecticut has really gone far in lifting that negative stigma attached to seeking supports. Our families and youth told us that they need greater awareness of community-based supports. A number of moms in particular said that they had children with some complex behavioral health needs, and they found unique support groups or innovative services actually within Facebook chat groups rather than on some formal website where they thought they in fact could be accessed. So how do we really inform our community pathways population of what is out there in the communities? Our families wanted connections to peers. We are the professionals, but peers live these struggles and they live this work every single day. And that was really a very poignant set of conversations we had about the peer involvement. Families know best as what they need. One mom, I loved it when she said, you know what, when you come into my house or anybody comes into my house, put down your checklists, leave all that stuff in the car and just sit and get to know me. So by listening to our parents and youth with lived expertise, we're going to understand more about how they view engagement and how they would like to be spoken to and how the manner in which they are going to jointly assess the issues that brought them to somebody's attention can in fact be worked out. What we also realized is we really have to be careful and be mindful of our language. We're talking a lot today about prevention plans. Yet if you ask a parent or a youth about a prevention plan, some of their responses are, oh, so without this plan, you think I'm going to harm my child? Do we have a prevention plan or a plan of support? And what are we really trying to implement here? I understand the federal regulations that were put into the Family First legislation that talks about a child needing to be at imminent risk of removal or imminent risk of placement into foster care. But think about the impact on that child and youth who are part of the planning with us, if in fact they hear that language. Here's the challenge for us now in Connecticut, is we've brought our families in, they informed our plan, and we have given them our word that we are now going to set up the exact systems that they think would best serve them and would have prevented them in some part from coming to our attention. Now we have to produce. And Dr. Davis and I are going to talk in the very near future about how we continually engage our parents and youth with lived expertise and in bringing them in. I thought one of the ideas earlier about a community pathways advisory committee is a fabulous idea, especially if it's heavy with the parents and youth with lived expertise. Next slide, please. As I indicated earlier, and I can't stress this enough, for those of you still developing your Family First prevention plan, as best you can, make it your state's prevention plan or your county's, not simply the child welfare agencies. We refer to our plan over and over again as the State of Connecticut Family First Prevention and Services Act plan, not DCF's plan. There's a number of logos here of some of the partners, but certainly not all, who joined with us on this journey. You'll see DEMIS, the Department of Mental Health and Addiction Services. They are the adult serving group for substance abuse and behavioral health issues in Connecticut. In their work with adults, they informed us of what they're seeing on their end, and in fact, what families need. We know that the youngest kids in our communities are the most vulnerable. That's why it was especially important for us to partner with the Connecticut Office of Early Childhood, OEC, who have the youngest children in Connecticut under their purview for daycare and other supports. Favor is our advocacy organization. They are made up of parents with lived expertise. When we are now looking at the messaging for our community pathways and really working with parents and engaging with them so they feel comfortable if in fact they are referred to our outside entity, it's Favor that's going to be really pushing a lot of that messaging. Connecticut Department of Housing, again, is huge, going back to Maslow's hierarchy of needs, right? What do so many families say to us over and over again? We are unstably housed. It causes immense stress. We cannot afford our rents. Where we are living is unsafe. And our Department of Housing has really been instrumental in the development of Connecticut's plan. Last slide that I have before I'm going to kick it back over to Dr. Davis talks about some of the work we've initially done in Connecticut schools over the past couple of years that gave us a little glimpse into what we think our community pathways organization could in fact do. For example, we embedded 3 investigators in 3 schools in one particular location, Waterbury, Connecticut. Each one of those investigators was taken totally offline from receiving reports, and they became literally part of the school staff. And they were there to answer questions, connect families to tangible and concrete supports, make that recommendation to a family who came in and said their child maybe has an emerging behavioral health need and they didn't know where to go. Working side by side with teachers to help them understand the difference between a child abuse and neglect report and a family that maybe needs support versus surveillance. Why did we start this in our schools? In Connecticut, in 2019 alone, school employees, school educational professionals made almost 11,000 calls to our child abuse and neglect care line. 87% of the time that we investigated a report from a school personnel, it was unsubstantiated. We did not find abuse and neglect. However, it doesn't mean their report was wrong. It means that maybe what they were looking at the end of the day, thankfully, wasn't abuse and neglect. But what are we left with? We still haven't identified needs in thousands of families across the state, just that came to the attention of schools altogether. So what we've learned over the past couple of years by having workers embedded in schools is families don't need referrals to services. They need that connection. They almost need it. They need more of a care coordination model. It'd be easy for me to say to one of you, oh, if you want services, go to Waterbury Youth Services. But isn't it better if I sit with you and we make that call together? And I know I then have a warm handoff with you to the program that I think is going to meet your needs. That helped inform some of our community pathways work. Again, navigating transportation for kids. Where do I go if I'm behind in my rent? My utilities are about to be shut off. Are there services out there? Are all questions that our investigators are fielding on a daily basis. Have we seen a drop in new reports of child abuse and neglect made by the 3 schools where these pilot workers have been working? We've seen a drop. It's somewhat been impacted by COVID, but we have seen some movement away from reports being made to us and connecting families truly to where they need to be to prevent them from coming to our attention in the first place. So that being said, I'm going to segue back over to Dr. Davis again.
Thank you, Ken. So we gave you a high-level overview of our plan and how it was developed. And one of the things that we realized when we stepped away from the table was that for our community pathways population to meet the needs, we needed money. We had this very bold, robust plan to address the needs of our families outside of the child welfare system, but we knew that we needed money. So to stand it up, our leadership went to legislator to share the vision, requesting money to fund the care management entity. Next slide. I'm sorry, I forgot to say click a slide. Thank you, Kush. So, but we also recognized that we needed some additional resources. We looked internally for what was available to us internally to support the installation of our CME, as well as externally, what were some of the other resources across the state, partnership with other sister agencies to stand this up, to ensure that our CME had the ability to coordinate a vast array of services outside of the Title IV services, to ensuring that those families, our community pathway families, receive the services and supports that they needed, regardless of the funding source. For us, we embodied that no wrong door philosophy. Our CME will accept all referrals, regardless of where they come from, or regardless of money's lack of funding or insurance coverage. Ken?
You bet. Okay. We can go to the next slide. So we've talked a lot about this care management entity, right? So we have an existing care management entity now that already is responsible contractually to handle a number of families to prevent them from coming to our attention, such as they work very closely under the Connecticut Behavioral Health Partnership, which is a collaboration between DCF, our Department of Social Services, and Department of Mental Health and Addiction Services, to create an integrated behavioral health service for kids. They also oversee intensive care coordination. So when a child is in an emergency department, awaiting placement somewhere up to and including discharge home, or in a psychiatric facility, the ICC, the intensive care coordinator, works with that family to set up services so that child can safely return back to the community. We've also contracted with our care management entity to handle voluntary care management. And this was a really important piece here in Connecticut, where we listen to our parents and youth with lived expertise and community providers. In a previous system, if you wanted to access voluntary behavioral health services for your child, you had to come through the child abuse and neglect care line and be assigned to a regional office worker. So basically you were coming to DCF asking for help, and now you have a DCF worker showing up at your door. Although we went there in a voluntary manner, it didn't feel good. And it prevented families from accessing help because they thought, geez, I have to call DCF. Now somebody's going to think I'm abusing and neglecting my child. What I really need is support. So we contracted with Carillon Behavioral Health, and now families who are requesting voluntary care management go directly to Carillon Behavioral Health. You don't have an open case with Child Protective Services. You do not have to worry about DCF knocking on your door. We've also contracted with our CMA for a program called Integrated Family Care and Support, IFCS. That program accepts families after the Department of Children and Families has completed an investigation, and we have not found abuse or neglect yet. We do believe there are risk factors, and if the family does not receive some support, there's a high probability that family is going to come back through our door. And so with the family's agreement, at the end of an investigation, we close our case, we give the family to IFCS, who provides a case management care coordination model to ensure that family is engaged with services moving forward. So one could argue that our community pathways model is already up and running for two particular groups, the voluntary care management and integrated family care and support. As we've articulated, where we're going though, is to set up the third or the fifth pillar of our care management entity, so families can be referred directly there for whatever type of support they need, as long as it's not abuse and neglect, and receive supports to prevent them from getting worse and from having to come to the attention of the Child Protective Services Agency. Next slide.
Okay, great. Thanks, Kim. So we've done a lot of work since our plan was approved back in March of 2022. Some of our installation activities really required that, again, we identified our community partners to ensure that their voice always informed the development, not only of the plan, but also the installation of Family First. We are now actively working on installing a shared community portal that will interface with our care management entity to ensure the tracking of all relevant Family First data elements, and it will also include the integration of our child-specific prevention plan. Our claiming process will happen behind the scenes, and it will not impact the family service experience. So we're working with our IT data folks to ensure that the information is collected will be transmitted to our revenue enhancement department so that they can approve the family's eligibility, as well as begin claiming for those EBPs approved in our plan. We have also developed the business process map that will inform the development of our practice and policy and ensure that it aligns with our department's practice and policy in addition to what is approved in our plan. Training and onboarding of the CME staff has already begun, but it will also ensure that everyone has the necessary skills and competencies. Our training will include family first orientation, the child-specific prevention plans, to include strategies that are needed to develop, as well as to adjust and to monitor child safety and the family's progress. In addition to that, we're developing training for strategies to assist the CME in identifying what information is needed to make a candidacy redetermination recommendation to the department. Now, because our funds reimbursement is going back into the state fund, we're really hopeful that our legislature will see a return and will support funding of additional EBPs that is not currently in the clearinghouse to meet the needs of our Families First population, our Family First candidacy population. We recognize for the EBPs that are currently in the plan may not necessarily meet the needs of our community pathways population, but we know that there's some EBPs that are out there and available currently in use that are meeting those needs that are not on the clearinghouse. And we're really hopeful that our legislator is going to see that return and we will see some additional funding to sustain not only Family First, but to also enhance our current service array for our community pathways population. Next slide, please. And now I want to turn it over to Ken.
So I think we're almost at the end here, right? So the goals versus reality. Well, the reality is we are building the plane as we fly. What makes me a little nervous is the picture of the plane that we have only has a wing on the right. We have to develop that plane to have a wing on the left as well, so it's successful. It's iterative, right? It's going to take time. We're going to need to be quick on our feet. We're going to need to learn and talk with our CME and talk with our families about their, about the experiences across Connecticut they're having. We can't do this alone, right? There's going to be a lot of work that's going to need to be done on marketing. And here's something that I think all of us should consider because Connecticut is grappling with this. When we market our community pathways, most likely we need to be present when those discussions occur between our care management entity and mandated reporters. So we can say to our mandated reporters, look, if it's abuse and neglect, come to us. For any other concern you have, a risk factor, somebody needing support, you don't know what else to do. We need you now to move that family to the community pathways, to the care management entity. And I think our mandated reporter groups need to hear us say that so they understand the liability is not solely resting on one particular agency. We've developed a different outlet for families and we are blessing the system. However, when in fact we talk about this work with families, I don't think DCF should be at the table. I think that should be our contracted provider. So there is distance between this program being viewed as another DCF program, because you don't need to come to our attention if you're part of this program. The goal, no wrong door solution for families seeking support. We want to get upstream. The end of the day, we want to shrink the CPS footprint that DCF Connecticut has in our communities. So less reports coming in, more supports within the communities. Limit surveillance and prioritize family privacy. Continue to develop formal and informal partnerships between agencies and providers, and provide mandated reporters with an alternative. Like I said, I know somebody asked in the chat, have we done work with our mandated reporter community and with our mandated reporter statutes? Not yet, but we are formalizing what we think we want to do and gearing up for next year's legislative session to see how many times we can make changes. So I think that's it.
Thank you so much, Sharon and Ken. I see we have lots of questions in the chat. That's always a good sign. I mean, folks are engaged and you've sparked their curiosity. We're going to hold questions till the end and move straight to Natalie Carver in DC's presentation, and then we'll get to as many questions as possible at the end.
Now I'm unmuted. Good morning, everyone, or good afternoon, depending on where you are. My name is Natalie Craver. As you all heard in my introduction, I'm our deputy director within our office that oversees our Family First implementation. And I'm really excited to talk with you all today because from the presentations that you've heard so far, DC is exactly in alignment with all of the previous speakers in our work and are implementing very similar strategies. So even though we're implementing similar strategies, we are doing it a little bit differently. So excited to share with you what we're doing in the District of Columbia. So a little bit about DC to start, if I can get the screen to move. Yep, too far. Go back one. Great. So a little bit about DC. We have both state and local functions within our Office of Child and Family Services Agency. So we are the Title IV agency for the entire jurisdiction of the District of Columbia. We are partially privatized for foster care. We have always supported youth in care up to age 21. Currently, all of our CFSA social workers have an MSW. That is based on being in a court receivership status for over 30 years and just exiting that lawsuit last year. So that was a requirement. We actually, just for awareness, received approval from our Board of Social Work to start to hire BSWs in addition to MSWs. So that's also a workforce strategy that we're implementing now in the district. We have a really strong service array in the district, as many places do. Medicaid and MCV, the maternal, infant, and early childhood home visiting federal funding, provide for a lot of the services that are already listed on the Title IV Prevention Services Clearinghouse. So in DC, we've had to think very strategically about what can we do with Family First? How can we maximize the opportunity, knowing that our jurisdiction already has many of these services paid for using other funds? For us, relationships are critical. We've always said that we are the agency. We are one part of the broader system, and love the new language around child and family well-being system creation, and that is absolutely where we're moving. We additionally, which I'll talk a little bit more about throughout this presentation, we have a really long history of partnering with community-based organizations, most specifically organizations called the Healthy Families Thriving Communities Collaboratives. These are 5 nonprofits that support all 8 wards of the district. And approximately about 1,000 families every year are served by these collaboratives. So they have a really deep impact on families who currently come to the attention of CFSA and families who also do not. So this slide shows us a little bit about the history of prevention in the district. And this has really been iterative for us. So Family First has been a really key inflection point within our prevention journey. But starting back in the mid-90s, we built those partnerships with the collaboratives, and they've supported and acted as our child welfare case management providers for the district. So when families can be served in their communities, we have a history of referring families to community-based organizations for services. In 2020, very strategically, and created a did my microphone just change? I want to make sure everyone can hear me.
It just changed.
Can you still hear me or no?
Oh, there we go.
Okay.
Yes, we can.
I thought something just happened on my screen, but not wearing any microphone. So hopefully it'll stay. So Kush, let me know if.
Yep, I will. You're good now.
All right, great. So our 4-pillar strategic framework really focused on how do we narrow the entry point, or what we call the front door, to the child welfare agency. How do we support families who can stay in their communities, and how do we provide supports when a family does have to become involved with our agency? So we had 4 pillars representing our strategic framework that really helped us re-emphasize prevention as a key priority. We were a Title 40 waiver demonstration project site from 2014 to 2019, which also allowed us to test a lot of evidence-based interventions and use prevention funding very flexibly. So when Family First came out, we were one of those jurisdictions that felt the cliff of moving from the waiver and then having Family First. And that created a really big funding gap for us that we've had to, and very grateful for the transition funding to help us through that. So when we implemented Family First, we were the first jurisdiction to receive approval of a plan. So we've had quite a bit of runway now to actually build and now implement the work. We decided to have a companion initiative called Families First DC. And that's because our candidate definition was very moderate. We only included families that already had a known interaction with CFSA in our original candidate populations. We also built in a community pathway, though, that said if a family has come to the attention of CFSA through an investigation or case and now can be served in the community, then we'll refer families to our collaboratives for supports. So from day one with our original plan, we had a community pathway built in, but it was not an upstream pathway. It was based on you've already had a report to CFSA, and we now can support you flexibly with community supports. And then finally, we are a Thriving Families, Safer Children round 2 jurisdiction. And we have been working on that child and family wellbeing systems transformation work. So that's our trajectory. That's why we are where we are today. And I'll talk with you a little bit more about where we're going and what we've done. I have to remember to click the little arrow. Okay, so I did mention already about our collaborative partnerships. So again, 30-year relationships, 5 nonprofits, they all represent different localities within DC. And they are really strong, trusted partners in the city. So families can go to these collaboratives on their own for services and supports, parenting programs. We also provide flex funds or concrete supports to all of these collaboratives who can provide utility assistance, rent assistance, school uniforms, whatever a family needs. We give them funding to creatively support families with immediate needs. So that's been also a major reason why families engage with the collaboratives when otherwise these are voluntary services when we refer them. And then, like I said, our family success centers through Families First DC use the Family Resource Center model that you may be familiar with through the National Family Resource Network. And we pick the locations where these now 11 sites are located based on substantiated reports of child abuse and neglect, crime and violence data in those neighborhoods, and then an array of social determinants of health that really helped us focus and pinpoint these specific neighborhoods most need services and resources and supports. And really similar to the idea of case coordination, we call it service navigation. How do we help families navigate really complex systems to get access to the services and resources they need? And each of these family success centers has a community advisory council that's made up of residents from their own neighborhoods to actually advise what should the programming look like in our neighborhood. So it's not the nonprofit that's organizing all of this. It's actually the community advisory council that are paid board members, and they receive a stipend, and they influence each family success center's work and programming. So I did want to take a moment to pause and just say that the Office of Community Partnerships in DC is pretty unique. We have a dedicated group of staff that are completely dedicated to prevention work. So when I started 5 years ago, we were a team of 5, and we're now over 30 individuals, and that a lot has had to do with Family First and how we've implemented the legislation and the types of programs that we now offer. So in addition to myself as the deputy, we have decided to bring our evaluation capacity in-house. So instead of contracting out for fidelity monitoring and evaluation work, we have a team that does that within our office. We also manage our grandparent caregiver and close relative caregiver programs that focus on subsidy for kin caregivers and kinship families. As well, we are bringing in and rebooting our 211 in the district, which has been defunct for over 10 years. So you'll now see within our primary prevention area, there's going to be 5 staff that are about to be hired to reboot 211, which is a big part of our long-term primary prevention continuum. And then we have a number of staff that you'll see noted as prevention specialists, and that means that they support evidence-based programs that may be in a family's prevention plan. So through grants and contracts and MOUs, we partner across the city to make sure that services are in place, and that if a family has a prevention plan, we have staff that are there to help with eligibility determination and help navigate services for social workers, because a big finding for us is that social workers are not experts. They when it comes to services, they might know that a family needs a behavioral health intervention. They may have an idea of what service, but they don't know that provider's current capacity. They don't know whether or not slots are available, or if that provider now has to have a wait list. There's so many nuances to when you're navigating social services that it helps to have someone on your team who could be a part of that social service navigation experience for a family. So that's really important to us in this team as well in our work. So some of our biggest lessons learned and principles for our success is that visioning big and starting small. So that's probably intuitive, but that's how we built that out. And it's similar to Connecticut. It's our state's plan. This is not CFSA's Family First plan. It is the District of Columbia's plan. In the short term, our leadership commitment from our director, our deputy mayor, our mayor's office has all been critical. So having that buy-in across, saying this is a citywide effort and activity, has been a big part of our success. And then long-term, and where we really are seeing our success today, is that we have tried to bake Family First into day-to-day business. It is not an initiative. We do not promote it as a thing. It is just how we operate. And that is a really important part of social worker and staff buy-in. Another big part of how we've implemented in DC is that we've picked our low-hanging fruit. We have not tried to implement anything that has required a substantial lift or major investment. That has allowed us to be really agile, to move quickly, and to create partnerships very, very seamlessly. So I'll talk more about our current community pathway that we're working to implement now around that. So again, we want to keep Family First administrative. We don't want social workers to feel prevention planning. We don't want them to have to do things differently. How do we just improve service delivery and access? And like I said before, service navigation is important, and that's where our community partnerships team helps out a lot. And engaging individuals with lived expertise has been a big and important learning curve for us. We had focus groups and more traditional stakeholder engagement in our initial plan development, but since our plan has been approved, we have created really robust opportunities for individuals and families with lived expertise to advise us along all the steps of our current work and our plan amendments that we're putting through now. So that's been a big part of our transformation. Just a little background, we, like I said, our first plan was submitted and approved by October of 2019. We submitted our first plan amendment in July of 2020. That's where we got motivational interviewing approved because it finally made it onto the clearinghouse. So we just resubmitted to get that, that EBP in our plan. We began claiming in March of 2021. So we have about 2 years worth of claiming under our belts, which is very helpful for now us seeing kind of where our investments in Family First are and how we do budget planning. And then finally, we have a plan amendment right now that's under review at the Children's Bureau that we're hoping to wrap up very soon. And that is our current primary prevention community pathway. So our current populations, we have 7. I'll just focus here on the 2 in bold. So this is where we're currently doing our claiming. Our children who are served through our collaboratives, our community pathway, following a CPS investigation or closed case, whether it's an in-home case or an out-of-home case, we support any referral to a collaborative that receives a prevention plan, and families can be supported in their communities. We're claiming for those supports now. And then our other key population is children who are served through our in-home cases where they're receiving intensive case management with CFSA social workers. So those are the 2 areas we're claiming, but our other populations are also very important, and all of these staff who support families have all been trained in motivational interviewing, because that is the basis of our case management model for all of our staff and our community-based organizations. I'm sorry, I skipped forward. So just a note, we put in our plan and called it a comprehensive prevention plan over 25 different services. I wanted to show you that we're only claiming for, or we only have approval for 2 and we're only claiming for 1. So we wanted to show how big the service array is in the district. We wanted this to be a comprehensive plan that everyone felt included in and can see themselves in, but our claiming strategy is much smaller. So that's part of the slice of how Family First is part of our broader strategy for prevention. It is not everything. And then motivational interviewing, as I said before, that is really the baseline of how we think about Family First claiming in the district. All of our workers are claimed to support families with that motivation to change, thinking about how we are interacting and talking with families and how we're helping them figure out what their next steps are. Often it takes that before you even get to a longer term EBP in the first place. And that was our biggest piece of feedback from our families throughout this process was the person who made a difference for me was my case manager. So if we know that families really feel like their case manager is the person who made a difference in their lives, then we should invest in that case management support. And that is what we did in terms of focusing on motivational interviewing, as well as other EBPs. So knowing the opportunity of Family First in the district and focusing on claiming for motivational interviewing based case management, we have been thinking about how do we take that further upstream at this point. So we've seen the opportunity to think about 50% claiming for Family First and thought, how can we continue to see the success we've had of claiming for secondary prevention and start to think about how do we do that, but also be respectful of privacy, not wanting to extend the reach of child welfare. I've seen some of the comments coming through the chat about those questions, and that's been very important to us as we've been thinking about this. So what we've decided to do, and before I get into that, I have a slide about claiming. So I do want to just explain a little bit on how we're doing the claiming here. Our in-home cases and our collaboratives, as I said before, those are the 2 groups that we're claiming for right now within our plan. Our in-home cases, we use a random moment time study, and our workers, the cost of service delivery is determined through that mechanism. And it's a per child per month rate. And you'll see that's the same for our collaboratives and our in-home cases. All of this is set in our cost allocation plan, which is still in the queue for approval, but we have confirmation and commitment from our regional office that we're well underway. So we've been claiming for 2 years with this model. And then our collaboratives, they're doing semi-annual 2-week time studies. So we're determining costs a little bit differently in the in-home cases with our Safe to Stay employees and our collaborative community-based providers, but we're still using that mechanism to determine a rate. And then MI as a service provided by those workers is how we've set up the service, and then a per child per month rate. So if there are more questions about that, I'm more than happy to talk with you all about it or refer you to our federal financing guru, Jay Murphy, who deserves tons of credit for all of this. But those are the nuts and bolts of our claiming infrastructure. And again, on our collaborative community pathway, I just want to be explicit here about how we've structured this to work with the federal legislation. A call comes into the hotline. It's either an investigation or a closed case that gets referred to our collaboratives. A prevention plan is created as part of that transfer process to actually do that warm handoff to the community-based collaborative organization. The collaborative is then responsible for receiving that case electronically. We've created a community portal to create that language between our SACWIS system. We're moving to CWIS, but currently our SACWIS system, and our nonprofit organization who we, through contract mandate, use our community portal. So that's a requirement of their contract. They're responsible for managing the prevention plan, adding services, removing services, and monitoring safety and risk formally and informally. So those functions all are within our collaboratives. And then our CFSA employees, those prevention specialists, they support the collaboratives. They have to do the eligibility redetermination on an annual basis. We do that through the portal. So the collaborative would say, hey, this family's hit the 12-month mark, or 12 months of service mark. We want to renew them, and they can check that off in our system. That's the only involvement our CFSA staff have with prevention plans. If there's any safety concerns, they have to go through the hotline. So we want to make it very clear that these community pathway cases do not have involvement with the Child Welfare Agency. We're purely doing administrative functions to support the families. So I think with that context set, I am going to finally get into our community pathway. I think in another moment, I'm really teasing this. So thank you for bearing with me on our next community pathway. I do want to note here that our staff training for motivational interviewing was all conducted in-house by our Child Welfare Training Academy. We actually have a unit of staff that train all of our CFSA employees and all of our community-based nonprofits. And they provided the motivational interviewing certification to our staff. That has been an area of opportunity for us that we've seen. How do we continue to have staff maintain the fidelity and to go through trainings and retrainings and gain more skills? And we're now using a software platform called Listen, which I'll talk more about, to support that as well. This is a visual of the technology I mentioned a moment ago, the community portal. So it's a quick 5-step process about how you confirm the capacity of a provider, gather information, show the enrollment date and prevention services, and then we capture the start and end date of service. But it's up to our collaborative to track and manage those 5 steps. And that is how we relate to a prevention plan when we no longer have an open case with the agency. So Listen, as I mentioned before, we trained all of our staff in-house in motivational interviewing between, I want to say, like July of 2019 and October of 2019. So even before we had motivational interviewing approved in our plan. And what we saw over the next couple of years was that it was really hard to monitor fidelity to motivational interviewing when you have staff that are trying to do their work day to day. We're requiring them to take a test and have supervisors score it, and then have conversations and supervision, and doing that on top of all of the other requirements of work. So when we learned about Listen, we were really excited, and we have implemented Listen in practice since September of 2022. And I'll tell you, we are seeing like astronomical improvement in people's fidelity monitoring scores. In December of this past year, about half of all of our workers had completed Listen training. And now I think we're up to like 85% of all staff have completed Listen training. So the adoption is huge. It's been, I mean, I think we were in the 30% range before Listen. And now we have, you know, really, really good data to show that our staff are using Listen. They're monitoring to fidelity, or they're using motivational interviewing to fidelity. And we also, a big part of that too, was we baked into all of their SMART goals for their performance plans and their annual evaluations that you have to complete the Listen training. Like they have to do 1 hour per quarter, and that's it. And they're able to show that they're using the model to fidelity, which is really exciting. And we also, just for folks, I know that Listen and AI in general can have some nuances when it comes to language and the ability to listen and hear accents and interpret that correctly. We've been monitoring for that. And as part of the annual report that Listen gives us, we're looking at the bias of the technology, and they're going to give us a report that shows us how the technology is continuing to improve to support practice. So here I just have a very short clip I want to show you to even reduce how our staff look at the burden of training and retraining. We have completely automated training for motivational interviewing. So we just gave this free
Welcome to our first tutorial video on Listen. My name is Ophelia, and I will serve as your AI-based facilitator today. I'd love to take a few minutes of your time to introduce you to Listen and explain why CFSA has decided to give you access to that innovative platform. As a social worker or as a family support worker, you are already familiar with motivational interviewing, also known as MI. It is a collaborative conversation style that strengthens an individual.
All right, I think I pause that. So that's just a clip to show you that we just gave a script to this technology. This isn't Listen. This is just something our data team found. And now we don't have to take any staff time from our training team to do motivational interviewing trainings or to provide assistance with how to use Listen, because all of this is just baked into to the tech that we're using. So it's very exciting. And I just did something. Sorry, Kush. I just got rid of the presentation. So I think I need help getting it back.
I am at your service. One moment.
Thank you. I only have a couple more slides. So while we're getting the slides back up, what I will share is that The technology piece with Listen has been really big for us in motivational interviewing implementation. That has probably been the game changer for our staffs and our community providers' use of the system. And now what we're looking to do with our community pathway is bring on other government agencies that provide case management. Specifically, we're looking at how to bring on our Department of Human Services that provides homeless services case management for families who are entering shelter or rapid rehousing or other subsidy programs within the district. So what we see, thank you, Kush, I really appreciate it. And I will go to the next slide if I can.
Oh, I'm going to do it for you.
Great,
Here.
thank you. I think that's best. Thank you. So perfect. So yes, families who are identified as experiencing homelessness or at risk of experiencing homelessness as identified by our Department of Human Services are our new candidate population. So we wanted to focus on government first because we thought it was very important that families feel like government is all part of kind of one system for families in terms of CFSA services, DHS services, it's all government services. So before we wanted to bring in a candidate population that was completely based in the community, we thought this would be a good stepping stone into how we support primary prevention through government services. We can go to the next slide. So as I said before, this new population coupled with motivational interviewing as the base case management model for these shelter and rapid rehousing case managers will allow us to claim costs of case management within the continuum of care for homeless services. You can go to the next slide. I think that we felt as we were starting this, and we started about a year ago to start implementing this work, that we wanted to leverage existing systems as much as possible, as we talked about before with our CFSA implementation, and use existing assessment tools, which we've been able to do and are really excited about a model where our CFSA staff would be able to see a prevention plan in the homeless services system. We are not building anything into CFSA system of record for this part of the partnership. You can go to the next slide. So just a visual aid. Our intake process that happens at the DHS Homeless Services Intake Center, that is where eligibility will be determined. Our staff will be able to go into the system and based on the homeless services eligibility process, determine that that family is a candidate for Family First Prevention Services. And then the case management across the short-term placements and permanent housing placements would be where we train in motivational interviewing, and all of those case managers would be able to support families and improve practice within the homeless services continuum. We no longer want to have multiple case managers involved in families' lives when you don't need multiple case managers. You just need your case manager within your current program to have the skills and the resources and tools to support you. Next slide. So this community pathway in our second plan amendment underway now, like I said, it's really helping us do a lot of what was talked about at the beginning. Coordinate our health and human services agencies as much as we can into a child and family well-being system, enhance training for our providers, streamline case management, and ultimately the federal funding will be able to pull down through Family First will allow us to free up lots of local dollars that currently go to homeless services case management costs. So it's really exciting to think about what we can do as a city once we have been able to fund other government services through Family First. Next slide. So that is it. Thank you very much.
Thank you so much. Such creative ways of thinking about how to support families based on what the families are saying. So let's see, how are we doing on time? We've got about 6 minutes left, so I'm gonna try and get to as many questions as possible, and I'll direct it to where the question makes it possible. I'll direct it to a particular presenter. This is for Kathy. If you're still here, Kathy, will there be a connection to the community pathway work with the California's Community of Schools effort? Oh, you're on mute still, Kathy. There you go.
You know, hopefully so, Kush. I think that depends on each county, but that is what we are encouraging folks to do, to look at the other initiatives that are occurring across systems and make sure that they are incorporating all those other initiatives. You know, hopefully with the implementation of the state advisory committee also, that is something that we can encourage in our work with that Department of Education.
Great, thank you. And then if there's a question about how folks get involved in the task force, what that process is like.
Well, if you're speaking about the mandated reporting,
that one.
community supporting task force, we are going to be actually getting out more information about how you can become involved. We have not finalized the application process yet, but we hope to do so within the next, 2 to 3 weeks and get that information out to folks. But I would also encourage people to reach out to the Prevention and Early Intervention Committee and get involved in the activities that we're doing there as we work on the recommendations to further them out, and also the State Advisory Committee. Those processes will be available, and anybody who's interested, I mean, for the time being, since my information is on here, you can reach out to me and I can connect you. But that information is on the State Child Welfare Council website also. So again, you can join the PEI committee, and we will also be posting out information about the task force and that application process to the broader community.
Great, thank you, Kathy. This one is for Connecticut, either Sharon or Ken. Does Connecticut have counties? And if so, how has it been able to assure some level of a consistency and congruency of practice across the state?
You got it.
There's
Ken?
a really easy answer there. We are not county based. We are a state administered system, which makes the pain some of you feel with your systems a little bit easier on our end. So it's one plan for everybody across the state.
And then, I think I'll just stay with Connecticut. In terms of EBPs, like we saw how DC is sort of dealing with some of the workforce challenges in terms of times using Listen. Anything to say from Connecticut's viewpoint on EBPs and how you're thinking about fidelity?
Sharon, you want to start?
I'll start. There 5 of the EBPs approved in our plan are currently under contracted through the state, 3 through the Department of Early Childhood, and 2 through Department of Children and Families. So we have program leads that are monitoring overall compliance and fidelity of those particular EBPs. There are 2 that we're still looking to onboard. So that has already been built into the work that we're doing. So it takes away some of that extra work that we need to do. Ken, you want that?
You said it all. Thank you.
Great. This is room for a couple more. This is for you, Natalie. How did you address the barrier of sharing data with the collaboratives? And a 2-part question, actually. And what is the rate of engagement with families when they're referred to the collaborative ultimately?
Yeah, it's a great question. So we do have a universal release of authorization form that we created when we launched Family First. So before a CFSA social worker refers to any social service within the district, they get that release, and that covers all of our service referrals. So if a family wants services, they sign the release. I think because it's voluntary, I want to say about like 50% of families who are referred accept services. And then there's that connection point between they've accepted services and then actually going to that service. Of families that get to the intake process, about 80 to 90% continue. But there is that drop off between that initial group who is referred and then who ends up engaging in the service.
Great, thank you. Perhaps last question for you, Natalie. At one point, DC system was bifurcated. With regard to law enforcement, is this still the case, and does this impact your efforts?
I think I need a little bit more information about what is being asked. I'm not familiar with the
Okay.
application.
Well, we might have them reach out to you then, because we are officially out of time. I am going to share our last slide. It's my clock telling me we're out of time. and we will send you off into the remainder of your afternoon or evening. So like we said earlier, the survey and certificate are in the chat now. Please go ahead and register for our next learning forum, which is the Building a Trauma Focused Service Delivery System. So you've heard everything. Okay, so how do you make sure that's all trauma focused? You'll have a recording and resources in the next 2 days, and Caltrin Connect will be in your, there'll be an message about what else is offered through Caltrin with regard to this prevention conversation. We want to thank you for your time. We want to thank you for your attention. We want to thank you for the work that you're doing. And we want to wish you a very, very happy rest of your Wednesday. Thank you, everyone.